Feline herpesvirus 1, or FHV1, is a globally distributed, highly contagious alpha herpesvirus that exclusively infects felids, including domestic cats, cheetahs, and lions. In susceptible cats, infection causes feline viral rhinotracheitis, or FVR, which is inflammation of the nasal passages and trachea. FHV1 features a double-stranded DNA genome, an icosahedral nucleocapsid, a viral matrix, also called the tegument, and a lipid bilayer envelope studded with glycoproteins. This envelope, stolen from host cell membranes, helps FHV1 evade the immune system, but also makes it short-lived outside the host, vulnerable to desiccation and disinfectants. The glycoproteins facilitate host cell attachment and invasion, and thus determine tissue tropism. Infection is divided into two phases: acute and latent. When a naive feline host is exposed to the virus, it invades and replicates within cells of the upper respiratory tract, including mucosal cells of the nasal passages, nasopharynx, and upper trachea, and epithelial cells of the conjunctiva, tonsils, and mandibular lymph nodes. After a 2 to 6 day incubation period, acute infection produces severe ocular and upper respiratory disease. Clinical signs include depression, inappetence, sneezing, pyrexia, conjunctivitis, and corneal ulceration. This is accompanied by copious production of oculonasal discharge, which gradually becomes mucopurulent, resulting in crusting around the external nares and eyelids. The acute phase can last 1 to 3 weeks, during which the virus is shed in large quantities via the ocular and nasal secretions before resolving spontaneously. However, once recovered, the cat is considered a carrier. This is because, during initial infection, FHV1 also invades the mucosal sensory neurons, traveling up their axons to colonize the trigeminal ganglion and establish latency. Here the virus is mostly dormant but can undergo spontaneous reactivation, causing recurrent disease with low-volume viral shedding, which can last up to 2 weeks. Known triggers of reactivation include stress and corticosteroid use. Transmission occurs primarily by direct contact. However, transmission via fomites may occur in dense population conditions. As such, cats in shelters, catteries, and colonies are at the highest risk of infection. Diagnosis is typically made based on empirical evidence, but definitive diagnosis can be achieved by performing PCR on conjunctival tissues or fluids, but only while there is clinical disease. FVR is typically managed with supportive therapy. Broad-spectrum antibiotics are indicated in acute cases to prevent secondary bacterial infections. Mucolytic drugs and nebulization with saline can help ease respiratory congestion, and eye drops or ointments can help reduce conjunctival irritation. Since olfaction is impaired, food should be warmed up and highly palatable to stimulate appetite. Being a DNA virus, FHV1 has high genomic stability, such that only one serovar is known to exist. Therefore, vaccination is extremely effective in the prevention of FVR. Initial doses at 9, 12, and 16 weeks of age are recommended, followed by annual or triennial boosters depending upon risk of exposure.